Hello everyone, I am Martie Weege and welcome back to your ETAT training course. Today we are going to do module 3A on circulation, and once you get to this module, you should have gone through airway and breathing. So let's talk circulation. Circulation and shock goes hand in hand because shock is because of inadequate circulation. Shock is still one of the leading causes of death in children, and early recognition and treatment is absolutely critical for us to save lives. Although we get different types of shock, like hypovolemic shock because of dehydration, like distributive shock or septic shock or cardiogenic shock, we know that the initial symptomatic management of all types of shock remains more or less the same. By the end of this module, I want you to be able to assess circulatory collapse, which is also defined as shock. So shock is the inefficient oxygen delivery to tissue. I want you to understand the importance of doing a nutritional status assessment during the treatment of shock. I want you to be able to treat shock, know the types of fluids, the amount of the volume, and the rate, how fast we want to give fluid, and understand the reassessment, and that is key to successful resuscitation. We want to stick to our A, B, C, 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 D. Once you get to circulation, you've managed and assessed the airway and breathing, and you now need to assess and treat circulation. There's also a special section on cardiopulmonary resuscitation, but hopefully, if we can identify the patients with shock and manage them early, we will have some patients that will hopefully not need CPR because we've done a good and thorough assessment and treatment of their shock. So if you do have signs of circulatory failure or collapse, which is shock, that is an emergency sign. How do you assess circulation? First of all, I always want to touch the hands of the patients and feel, do they have warm hands? If they don't have warm hands, I want to assess their capillary refill time. How do I do that? I apply firm pressure to the patient's fingertips for 5 seconds, release the pressure, and then count how quickly does the refill time come back. And if this is more than 2 seconds, this is one of the signs of shock. Next, I want to feel the pulse, and often the radial pulse is most accessible. Is this pulse weak and fast? And if all 3 of those signs are present, I've got cold hands, capillary refill time more than 2 seconds, and a weak and fast pulse, then I know my patient has got shock. If I only have 2 of these signs present, then it's called impaired circulation, which is a priority sign. Let's briefly talk about capillary refill time. One of the things that can affect both our temperature of our hands and our capillary refill time is the environmental temperature. So we need to make sure that our patients are assessed when they are in a nice and warm environment and when they are warmed up. Once we've done our circulatory assessment, so looking for the 3 signs of shock, feeling the temperature of the hands, going through our capillary refill time, and feeling the pulse. And if it's fast and it is weak, we have made the diagnosis of shock. Once we make this assessment, we next need to look at our nutritional assessment of our patient. And this is hugely important because this will now affect the fluid management for shock. So this is going to be a video that takes you through visible wasting. So in this little person, you can see the wasting, you can see the skinny little arms. In this little one, you can see the quality of hair is not good. You can see the dehydration with the sunken eyes. You can see the wasting of the little arms. But you can also spot the fast breathing that most likely is related to the metabolic acidosis from the dehydration. And that's why children that present with shock, the parents will often tell you, or the caregiver will tell you, that there's been fast breathing in this patient as well.
To determine if a child has edema of both feet, the health worker uses her thumb to press gently for a few seconds on the upper side of each foot. If a dent results in both feet, the child has edema. This child does not have edema. Edema is an important sign of kwashiorkor, a form of severe malnutrition. This child has kwashiorkor. This child has edema. The edema or swelling is due to an accumulation of fluids in the child's tissues.
Early assessment for circulation and identifying shock is absolutely life-saving. But we want to make sure that we are extra cautious in our treatment of shock in malnourished children. So how do I manage these patients with shock? And for all my patients where I identify shock, I want to make sure that if there is any bleeding, any external bleeding that I can see, I want to stop that with compression. I want to give all patients with shock oxygen, and this doesn't matter what their saturation is and whether they look centrally pink. All patients with shock needs extra oxygen for oxygen delivery to tissue. I want to keep my patient warm, and we know how important this is, especially in the patients with severe malnutrition. I want to establish IV or interosseous access as soon as possible. Take some bloods, but never forget to do the glucose. I want to make sure I secure the cannula well and immobilize the extremity, especially if I've done an interosseous line. Children with shock needs antibiotics early, especially in those patients with suspected sepsis. And we know sepsis is one of our main causes of shock. Now we want to get to the fluid bolus. Once we think fluid, we want to make sure we can answer the question of, is there severe malnutrition? Because that is going to be the factor that influence how fast I give my fluid bolus. Let's talk about that fluid bolus. First of all, let's talk about the type of fluid. We want to give a balanced crystalloid fluid like Ringer's lactate, Plasma-Lite B, or normal saline. But Ringer's lactate is preferred. If you don't have Ringer's, you can definitely use normal saline. How do I know how much to give? So for all patients with shock, we're going to give 10 ml per kg of fluids. How fast do I give this? So this is where we've done that nutritional assessment. If I have a patient with no malnutrition, I can give my 10 ml per kg fluid bolus over 15 minutes. If I've got a patient with severe malnutrition, I mustn't give that fluid bolus fast. I must slow down and give the 10 ml per kg over 30 minutes. And I can even slow it down more and give it between 30 and 60 minutes. So let's just quickly recap that management. I ask myself, is the child shocked? Is there any bleeding? If there is bleeding, I need to stop that bleeding immediately with firm external pressure and I need to keep that patient warm. I always give oxygen to all shocked patients. And then I want to give fluid. How much do I give? I always give 10 mils per kg, but if the patient is not malnourished, I'm going to give it over 15 minutes. If the patient has got signs of severe malnutrition, I want to give it slower, over 30 minutes. And then I must always reassess. Reassess. If there's no improvement, I'm going to give another 10 mils per kg. And this is different from the previous ETAT and from previous fluid guidelines, because this is almost half the amount of fluids over double the amount of time. So we've realized that if the more fluids, the more rapid we give, it doesn't improve the outcome of our patients. And then after 20 mils in total of fluids, if there's still no improvement, I can give a third 10 mils per kg of fluid. Again, if it's a patient with no signs of malnutrition, I can give it over 15 minutes. If there's signs of severe malnutrition, I want to give that over 30 minutes. We told you in the beginning of this lecture that reassessment is one of the most critical things of managing a patient with shock. So what does that mean? First of all, I need to have ongoing assessment and looking for signs of shock. Every time that I give a fluid bolus, I want to check afterwards, is my patient's shock getting better? Is it staying the same with no improvement? Or is my patient actually getting worse? So I want to look for signs of shock. I want to check for signs of heart failure. So what can this be? Fast breathing, a patient that becomes more tachycardic. It's very important to feel the liver size every time that you've given a fluid bolus. So children, for instance, with hypovolemic shock will very rarely have a liver to feel at the beginning of your management of shock. But a patient with cardiogenic shock, for instance, that's got a higher risk of going into heart failure, will have a liver that size that you can often feel in the beginning of your fluid administration. Reassess also means that we never, ever, ever leave our patient alone. We continue to reassess them until they are improving and out of shock. We never leave a patient with shock for a second alone, because we never know when they are going to deteriorate even further. So when we do the reassessment, we want to look at a specific outcome, and then we want to respond in our further management of the patient. So what can be the three outcomes? I either have a patient that's not improving yet, I have a patient that's getting better, or I have a patient that's actually getting worse and potentially developing heart failure. So how do I respond to this outcome? So if I've got a patient that's not improving, I can give an additional fluid bolus. If I have a patient that's getting better, that's the best feeling, I can stop my resuscitation fluid because I've known I've given adequate resuscitation fluids. If I have a patient that's getting worse and developing signs of heart failure, I want to definitely stop all additional fluids. So let's recap the management of circulation shock. First of all, I want to ask that question: is my patient shocked? How do I identify that patient? I have a patient with cold peripheries, cold hands. I have a patient with a cap refill time of more than 2 seconds and a pulse that is thready and that's fast. I want to make sure that if it's a patient that's bleeding, that I stop any external bleeding with firm pressure. I want to keep them warm, give oxygen, and then do a nutritional assessment before I give the first fluid bolus. All patients with shock can get 10 mils per kg of Ringer's lactate or saline. If I have a patient with no signs of malnutrition, I can give that fluid bolus over 15 minutes. If I have a patient with severe malnutrition, I must slow down with my fluids and give that over 30 minutes. I want to reassess a patient after each fluid bolus, and if there's no improvement, I can repeat that 10 mils per kg, but again at the same rate. If the patient is malnourished, I give over 30 minutes, and no malnutrition, I give over 15 minutes. When do we reassess? After each bolus. We reassess for fluid overload. We want to seek senior advice for fluid bolus management after we get to the third bolus. This is also what we call the tiger territory, the red zone. We now know that we're dealing with a very, very sick patient that's not responding well to our treatment. We also want to make sure that the glucose is corrected, the antibiotics have been given. If shock does not respond to our fluid management, we may need to consider intubation, ventilation, and ionization. So the last time, is my patient shocked? If yes, stop bleeding, keep the patient warm, give oxygen. Now we want to go to fluid. Give IV fluids, Ringer's or saline, 10 mils per kg. We're going to give it over 15 minutes if no malnutrition and 30 minutes if the patient is malnourished. We're going to keep on reassessing after each fluid bolus. If there's no improvement, I can repeat that fluid bolus, 10 mils per kg, same rate. Reassess after that fluid bolus. I can give a third bolus, but be aware and seek help once you've given 30 mils per kg. And just remember, if a patient is not shocked, you must not repeat another fluid bolus. And we just want to remind you that shock, you need all three the signs. A cold patient with a prolonged cap refill time and a pulse that is weak and fast. While the fluid bolus is in progress, you want to use your time because you know you are not allowed to leave the bedside in a patient that's shocked. You want to make sure that you do not ever forget the glucose and that you check and manage hypoglycemia, that the antibiotics has been given and that you reassess and reassess your patients. If at any stage there's an improvement, you want to stop the fluid bolus and calculate ongoing fluid or feed requirements. If there's any signs of deterioration or worsening, we need to think about heart failure. Stop the fluid bolus. Seek help and advice. Check the glucose. Make sure that antibiotics went in and consider intubation, ventilation, and inotropes. And rethink the possible cause of the. What can we do if we've got signs of improvement? This is what we all hope for. This is when you stop the fluid bolus and you continue with table 4, where you're going to look at maintenance fluid once the shock has resolved. If there is signs of severe dehydration, you want to treat according to module 5. If the patient is well nourished and the child has no dehydration, you want to continue to give IV maintenance fluid as half DD. Or if the child is malnourished, you should try and avoid IV fluids at all costs, and maintenance should rather be given via the oral or nasogastric route. Change maintenance over to oral feeds as soon as the child is able to tolerate feeds. Trust the gut as far as you can. Encourage breastfeeding. Reassess the child every 2 hours for the shock and fluid overload and every 4 hours for hydration status. So this reassessment counts once the patient is out of shock. If the condition is not improving, re-examine the child and reassess the A, B, C, 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 D, recheck the blood sugar, if shock, treat as per table 3, give IV antibiotics if not already given, and always discuss with a senior or with a referral center if you are unsure. So let's talk about intraosseous lines. So sometimes in shocked children, intravascular access can be extremely tricky. So when do I decide to go to an intraosseous line? So often for the very sick child, where do I go? I want to go to the proximal tibia. So that's on the anterior medial side of the tibia, and it's about 1 to 2 centimeters below the tuberosity that you can feel on your own leg and on that flat bit of the proximal tibia. What do I use? So the best needle to use is the pink short LP needle. It's often a 15 or an 18 gauge. You can use a 21 gauge as well, but it needs to be a hypodermic needle. Unfortunately, the 21 gauges often feels like they are a little bit too thin, so the 15 to 18 gauges really works very well. How do I do these needles? So first of all, you want to make sure that you work clean, aseptic technique, you stabilize the tibia, and in about a 90 degrees angle, like you see on the picture, and you want to twist and use a bit of a drill motion when you insert that needle. And you will feel a little give as you go through the bone into the marrow. And when you feel that give, it's the decrease in resistance. And that's really where you want to be. You want to stop and then aspirate. After you aspirate, sometimes you will get some blood back, but you don't always do. You want to flush. And the clue is really that if it's very easy to flush the needle, you are most likely in a good position. You want to check for any swelling. You want to make sure it never swell up or that there's no discoloration. And then you want to make sure that you secure that line very well, because as soon as those patients are out of shock, they're going to want to start kicking. So what is the contraindication? So infection over that area, a fracture, or if you've previously had puncture sites in that area. What can be the complication? So we know these lines can be absolutely life-saving, but we also need to make sure that we check regularly for potential complications. So line infiltration, they can block. Infection a couple of days after the line was in. There can be necrosis over that area and sloughing of the skin, so it's very important to take good care of these lines. So in summary, how do we make the assessment of shock? We have cold hands, a cap refill time of more than 2 seconds, and a weak and thready fast pulse. We know our patients are shocked. How do we manage these patients? We always want to give oxygen. We want to treat them with fluids, and we rather want to put in an intraosseous line early. So I always say you can have one try to put in a peripheral line, but as soon as you see that you can't really see visible veins, it's much easier and life-saving to go for an early intraosseous line. We can keep these lines in for 12 to 24 hours, and we can give most things intravascular, from intraosseous, from antibiotics, blood products, IV fluids. All of that can be given through our intraosseous line. How much fluid can I give? So we start with 10 ml per kg, and we can give it over 15 minutes in no malnutrition. And when we identify that the patient has got severe acute malnutrition, we want to give fluids much slower, over 30 minutes. Reassessment is key to identify the need for ongoing fluid boluses. You can look at the summary of the treatment of shock in your manuals at chart 4. First of all, you want to make sure that you stop any bleeding. You give oxygen, you keep the child warm. You insert an IV or IO line as soon as possible. Check the glucose and make sure you secure your IV or interosseous line. Now you want to give fluid in the patient that is shocked. So you want to make sure you do a detailed nutritional assessment. If it's a child without severe malnutrition, you can give 10 ml per kg of Ringer's lactate or saline over 15 minutes, and you can repeat this every time that you reassess, and you can give up to 30 ml per kg. If it's a child with severe malnutrition, again, the best fluid to use is Ringer's lactate or saline, but you want to make sure that you give the fluid bolus much slower, so over 30 minutes. You want to reassess after each fluid bolus, and definitely don't need to give more fluid boluses if the patient is not shocked. If you get to 30 ml per kg, that is now when we enter tiger territory. We want to check after each fluid bolus whether there's any signs of fluid overload. We want to discuss with a senior or a referral center for advice once we get to 30 ml per kg, and whether a patient doesn't need intubation, ventilation, and inotropes earlier. While fluid boluses are being administered, make sure that you check glucose and treat the hypoglycemia, give antibiotics, measure the pulse and the breathing rate very frequently, and check for signs of congestive cardiac failure. If there is any signs of heart failure, stop the rapid fluid administration and discuss with your senior. If there is improvement after a bolus at any stage, so the hands are nice and warm, the cap refill time is improved to less than 2 seconds, and the pulse feels slower and the volume feels good, you can stop the bolus administration and calculate further fluid or feed requirements. Blood should be given if there's hypovolemic shock due to bleeding in a child who is still in shock after the second bolus. Also remember that ceftriaxone should not be given in calcium-containing fluids like Ringer's lactate. The line should always be flushed before and after the administration of ceftriaxone. Maintenance fluid once the patient is out of shock, and you can look at your table 4 to recap the maintenance fluids of patients with no dehydration. To identify the patient with shock, we want to know whether the patient has got cold hands, has a capillary refill time of more than 2 seconds, and has a pulse that is fast and weak. Once we identify the patient with shock, we want to manage all patients with shock by stopping the bleeding. If there's any external bleeding, we want to do compression, give oxygen, keep the child warm. We never want to forget to do the glucose, and we want to administer antibiotics early. We want to give IV fluids in patients with no severe malnutrition. We want to give it a little bit faster. But in patients with severe malnutrition, we want to make sure we give less IV fluids and that we give that over a longer time, and we do frequent reassessments. You should get antibiotics. Thank you so much for your time, and now we're going to move on to the lecture on cardiopulmonary arrest, and that will be the next step of the circulation. Thank you very much.